Thanks for taking a few moments to learn about AAPA's model state legislation and guidelines for state regulation of PAs. These are the foundational documents and policy on which we base our proposed changes to PA state laws and regulations. It's abundantly clear that healthcare is changing. The ACA is giving access to more patients, technology is influencing practice, employers are transforming, and systems and payers and payment models are shifting too. AAPA has been studying these changes and planning for how to best position the profession through these challenging times. Starting in 2014, subsequent to discussions with a group of PA leaders at our Leadership and Advocacy Summit, LAS, AAPA began making substantive changes to how we describe the profession. We recognize that supervision is an archaic and unsuitable term to describe how PAs and physicians work together. We also recognize that the notion that scope of practice should be determined by physician delegation was also holding the profession back. And, although early on the idea that physicians should be responsible for care provided by PAs was used as a proxy for quality of PA-provided care, we agreed that the concept is no longer relevant or necessary. On the heels of the LAS discussions, the 2014 AAPA House of Delegates passed a resolution using new terms to describe PA practice. The policy now says, PAs are health professionals licensed, or, in the case of those employed by the federal government, credentialed to practice medicine in collaboration with physicians. PAs are qualified by graduation from an accredited PA educational program and/or certification by the National Commission on Certification of Physician Assistants. Within the physician-PA relationship, PAs provide patient-centered medical care services as a member of a healthcare team. PAs practice with defined levels of autonomy and exercise independent medical decision-making within their scope of practice. In addition to policy, AAPA has model state legislation for PAs. It has been updated several times over its 20-year history, but in 2014, it was clear that the model was due for an extreme makeover. A group of AAPA members from a variety of specialties and practice settings responded to a call for volunteers and over several months drafted groundbreaking changes to the model legislation. You can certainly do a side-by-side comparison, but here are the most important changes. References to the profession. The new model uses PA as the title of the profession. PA is defined as a health professional licensed to practice medicine under the statute. No more reference to any other profession in the definition of PA, and no use of the term physician assistant. Collaboration and teamwork. PAs collaborate with physicians and jointly contribute to the healthcare and medical treatment of patients. The details of collaboration are left to the PA physician team. The concept of supervision has been removed entirely, in keeping with the amendment to Academy policy. Scope of practice. PA scope of practice is no longer determined by physician delegation, nor is it limited to a specific physician's scope of practice. Instead, PA scope of practice is determined by the PA's skills, education, and experience. Agency. The concept that the PA is the agent of the physician has been deleted. Current advocacy efforts seek to have PAs specifically named in all relevant health law instead of authorizing PAs to be able to perform specific medical and surgical tasks as the agent of the physician. Accepting responsibility. Language requiring the physician to assume responsibility for the care provided by the PA has been deleted. Rather, the PA is responsible for their own professional actions. Primary care provider. A PA licensed by the state shall be included in the definition of primary care provider for all state programs, so long as the PA is practicing in the medical specialties included in the definition of primary care. Volunteers. The revised model authorized PAs to practice without physician collaboration when participating in volunteer activities. The model state legislation was reviewed and approved by the Advocacy and Government Affairs Commission and presented to AAPA's Board of Directors in May of 2015. In addition to the changes previously mentioned, other less sweeping modernizations were included in the new model, and we encourage you to read it along with the article introducing it in PA Professional. The model state legislation has specific language that can be incorporated into law and rules. It has an accompanying policy document, the Guidelines for State Regulations of PAs, that describes the collective values, philosophies, and principles of the PA profession as they relate to state regulation of PAs. Immediately after the model was amended, work was begun to update the guidelines. A group of AAPA volunteers was convened and got to work. The guidelines revision was drafted over a period of several months and submitted as a resolution by the Government Relations and Practice Advancement Commission to the 2016 House of Delegates. House members made minimal changes to the resolution, and new guidelines for state regulation of PAs were adopted in May 2016. Consistent with the new state model legislation, the new guidelines for state regulation of PAs include several important concepts. PA scope of practice consists of activities for which the PA is prepared by education and experience and does not tie PA scope of practice to physician delegation or physician scope of practice. Collaboration and teamwork provisions. All references to supervision have been replaced with collaboration. Details about how collaboration occurs are determined at the practice level. Accepting responsibility. Language stating that physicians should be responsible for PA-provided care has been deleted, the only exception being when the PA is acting on a specific physician directive. Independent PA Regulatory Board. The preferred regulatory agency for PAs is a separate and independent PA board. One of the most dynamic amendments to the guidelines authorizes state chapters to pursue even more progressive provisions that would increase PA practice authority should the opportunity arise. This has been an open question in the past. If a state chapter had the opportunity to do something more progressive, would they be at risk for violating AAPA policy? Here's what the guideline says now. Notwithstanding the above provisions, these guidelines recognize that medicine is rapidly changing. A modified model may be better for some states, and they should therefore feel free to craft alternative provisions. PAs practice team-based medicine with a wide variety of team members to include physicians. Language in state law should acknowledge consultation and/or collaboration between physicians and PAs in a manner that assures quality medical care and promotes access. This local opportunity exemption clearly allows chapters to move beyond the model or the guidelines if they have the desire and the opportunity. This is having an impact already. Several chapters have found that the word collaboration is a non-starter in their state. One state chapter working to enact provisions of the model is referring to physicians who work with PAs as participating physicians, and another is using consulting physician. Just to be clear, the new model and guidelines also include all of AAPA's 6 key elements of a modern PA Practice Act. PAs are to be licensed by the state with a license that is not tied in any way to physician licensure. There is no requirement for chart co-signature. Collaboration and scope of practice specifics are to be determined at the practice level. PAs are authorized to prescribe, order, administer, dispense, and procure prescription drugs and devices, and there is no limit on the number of PAs and physicians who can practice together. The model and guidelines also clarify that PAs can participate in practice ownership and that services provided by PAs should be reimbursed. Both documents stipulate that state laws, regulations, and policies should allow PAs to sign any forms that require a physician signature. Give these documents and the articles describing them in PA Professional a read. They are gaining wide support. State chapters across the country are working to enact part or all of the provisions they include, and AAPA is assisting them in state advocacy. I hope this helps you understand more about the changes to our model state legislation and guidelines for state regulation of PAs. Look for more videos about AAPA and the PA profession at aapa.org.